Okay, so firstly, thank you very much for inviting us to talk about our research today. My name is Dr. Julia Petty, and I'm an Associate Professor in Learning and Teaching at University of Hertfordshire. And I'm just going to hand over shortly, in a moment, to my colleague, Professor Dr. Celia Harding, who's from City University and St George's. And the other member of our team who is not with us for this session is Dr. Lisa Whiting as well, who's also at the University of Hertfordshire. So the research team is the three of us. So delighted to be here today online to present our work. And as Michael has said, and as you can see on the slide, we're looking at a study that we've completed on exploring neonatal nurses and parents' understanding of the factors that enhance and hinder communication and early interaction relating to premature babies and their parents. So I'm going to hand over in the first instance to start the presentation to Professor Celia Harding. I'm going to advance the slides, so Celia will let me know when to advance.
Okay,
thank
I'm
you,
ready,
Celia.
Julia.
Okay,
thank you.
Lovely. Thanks very much. Okay.
So just to introduce what we're going to talk about today, first of all, we're going to have an overview about why is communication important, because I'm sure many of you think, oh, this is something that's talked about a lot in neonatal units already. We have family integrated care, for example, where we talk about closeness and early communication, but we just wanted to qualify why communication is important in a little bit of more detail. And that led us to the rationale for our initial study, which we're going to present to you today. And then hopefully we have any questions that we may be able to answer with you today, or we have our email addresses at the end, and we'll be very happy to answer any questions you may have, particularly about our current study and the next steps. Okay, Julia, thank you.
Yeah.
So why is communication with preterm infants important? I mean, we already know that infants born preterm are at very high risk of potentially developing a range of speech, language and communication problems. But if we can actually support parents and nursing staff and allied health professionals to actually think about what the key skills that are necessary are for helping speech, language and communication development, we may be able to help people develop a very positive and comprehensive and supportive communication environment. Next slide, please, Julia. So if we think about why this is important, James Law and Lindsay and Dockrell et al. Have written a lot about children with speech, language and communication difficulties and how these difficulties can reduce educational attainment once in school. And we know that approximately 1.2 million children in the UK have significant speech, language and communication needs. This number, of course, includes a wide range of difficulties, and that includes those who have been born preterm, those with a range of learning needs and learning difficulties, and those with specific language and communication problems. Poorly supported speech, language and communication needs can impact significantly on social and educational achievements. So referring to some key texts cited here in the second bullet point, infants born preterm are likely to experience delays in getting their first words, problems with grammar rule learning, using sentences which are much shorter, so they have the shorter mean length of utterance expected compared with typically developing children. They tend to use fewer natural communication adjuncts such as natural gestures, which are extremely important for early interaction and first word learning, and tend to use fewer nouns and verbs, and overall have generally smaller vocabulary. In particular, Centenac et al. 2020 investigated infants born under 32 weeks gestational age, highlighting that this group have a higher risk of smaller expressive vocabularies and difficulties combining words. Therefore, infants born at a lower gestational age are likely to experience much greater speech, language and communication problems compared to peers born term. Specifically, Hinds et al. Report that some prems still have persistent speech, language and communication needs at 18 to 22 months corrected age. And we know that, as Reedy et al. Points out, that there are white matter differences between term and preterm infants, which may affect learning and development. Next slide, please, Julia. So one of the things that we thought was important to think about is, of course, the neonatal environment. And many of you will be very familiar with the range of research that talks about the problems of managing a neonatal environment, in particular the unfamiliarity for parents and families, the noise, the frequent activity that impact on both parents, families and infants. And these noises and interruptions can't really be underestimated in terms of providing that supportive environment that will enable people to develop the care skills and the early interaction that's so necessary with this vulnerable population. So managing this complex environment to support early communication can be, although it isn't always, but it can be challenging. And I think we're aware of many good examples of practice where we've worked previously, where the environment is nurturing and supportive. Next slide, please, Julia. So we know that very often in a lot of research from around the world, that intense non-speech sound exposure can often exceed the recommended decibel levels of around. And Farl et al. Writes about the importance of regular and ongoing, little and often training to remind staff, because Farl and his team found that one of the greatest main noise sources in some neonatal units tended to be staff chat and conversation, particularly between shift changes. We also know that rapid transition from the intrauterine environment, which has primarily a low frequency acoustic stimulation, can shock preterm infants when they're born early. And Monson discusses the deficit in language exposure that infants are going to experience post this early birth. Preterm infants experience a deficit of over 150 hours of language exposure, and staff in neonatal settings generally provide poor language stimulation. And by poor language stimulation, I don't mean that as a negative term. I just mean that nursing staff and allied health professional staff are often very busy and have a lot to do, so they might not have enough time to actually use the language to interact with the infants in the way that the parents might want to. But Zwinfer did find that some of the language used was quite limited and sort of short interactive bursts rather than sustained talking with an infant. We all know as well that caring for an unwell infant within a neonatal setting can impact negatively on parent mental health and well-being. Thereby, this impacts on parent-infant interaction and sustained opportunities for parent-infant interaction. Next slide, please, Julia. A lot of people say, oh, why are we talking about communication? Why is this important? We're already doing this. Isn't skin to skin time, reading cues, reading a book and bonding time with my baby communication? Well, yes, this is a frequent question, but these are all really important antecedent skills for building a really good, strong linguistic and interactive relationship between families and the baby that can be built on over time throughout the early years. Therefore, it's important that we clarify what early communication is and how we perhaps should be encouraging people to facilitate it. And it's a low cost and in many cases a comforting activity for parents to be involved in. Next slide, please, Julia. So language learning obviously is very, very complicated. It involves listening, anticipation, turn taking, linking keywords to familiar routines, using routines to build interaction, and therefore develop receptive language abilities. So understanding of language is happening alongside the expressive language skills. So this is so important for vocabulary and grammar acquisition, as well as word linkage skills in a range of contexts. We know that infants are socially predisposed to seek familiar faces and engage in social interaction. So skills such as eye contact, sustaining eye contact, having attention to another, listening and appreciation of familiar faces provide a really important foundation for language. And Cecchini reminds us how quickly typically developing infants can build a dynamic representation of a human face. In fact, Cecchini's research shows that the first 15 to 50 hours of life are really important for an infant in learning to map on to a familiar parent or family face. And Dominguez also stresses the vital importance of gaze in early interaction towards a human face to get that engagement so that you can build initiation and interaction into your communication exchange and think about the type of vocabulary that's important within your home culture and that you're going to be wanting to use with your baby. And finally, turning towards a familiar speaker and facially recognizing someone whilst vocalizing, being vocally responsive, so listening to the baby and responding to them, using facial expression, sustaining eye contact and using that all-important natural gesture, as well as the important key vocabulary that you're going to be using repetitively so that your baby can hear and learn, as well as modelling language use and learning pragmatic or rather interactive function are really important skills for babies. Thank you, Julia. Next slide. So just before I hand over to Julia, this thinking about what communication was led us to think about, well, what are the aims of our first tranche of research that we're engaged with? And we felt that, first of all, it's important to investigate what parents and nurses are understanding the factors that enhance or prevent the development of communication and interaction between preterm infants and parents within the neonatal setting actually are. And we wanted to gain some insight into what helps or hinders communication and to produce an educational intervention and resource for parents and nurses in relation to recognising cues and tailoring interactions to the capabilities of their baby. Okay, thank you. I'm going to pass over to my colleague, Dr. Julia Petty now.
Lovely. Thank you so much, Celia. It's a really comprehensive background, which has led really nicely to now presenting the research study that, as you can see up there, which the aims are highlighted, and as Celia has just explained, given the sort of background and the evidence base that there is to support that, and the importance of communication in terms of the context. So that's the background and the context. So in terms of the study then, the aims are there, as Celia has highlighted, and this work came about during COVID, actually, where Celia contacted myself and Lisa, my colleague, to see if we were interested in exploring this area further. And based on our previous work on exploring parents' experiences in other areas, we obviously welcomed any further research, particularly given the importance of communication. Certainly within an educational setting for myself as an educator, and the importance of that through the nursing curriculum. So it was I was very mindful of that being such a central part of my own teaching, but also that was great for me because it meant that we could further explore that within the neonatal field, but also, given the importance of communication as a sort of central tenet of what we were trying to do. So it led to us collaborating between City and us at University of Hertfordshire with this really very positive piece of work, which I'll now present. The first thing we did was obviously had to secure funding, and we were very lucky to receive a small grant from the Burdett Trust for Nursing. So we're very grateful for them to support this this particular project. So funding was the first stage, really, and we were successful with that. So in terms of the actual study details, so as I said, it was a funded study through the Burdett. That was the first stage. The second stage really was to apply for NHS ethical approval, and that obviously, for anyone who's been involved with NHS ethics through the HRA knows that can be quite a long process. But we eventually got there. I think it probably was getting on for a year between achieving the funding from the Burdett and finally obtaining sort of full ethical clearance through the IRS process and through HRA and through the Research Ethics Committee. It was a very positive experience, to be honest, because by the time that the ethical approval had been granted, we had all of our sort of partners on board. We had our parent advisory group, as you can see there, had been set up to advise and to help us with our documentation, with our data collection, i.e. our interview questions. We had secured our NHS trust staff, our gatekeepers in a particular trust, to enable access to our participants, both our parents, which I'll talk about shortly, and our nursing staff. So by the time the ethical approval was granted, we were sort of really ready to go with our the data collection, which again I'll move on to. So yes, again, we were very the aim was to explore both the barriers and enablers of communication, focusing on prematurity, but also thinking about parents and nursing staff as our participants. So as I've said, the recruitment was based within one NH trust in London, and that ended up being 2 neonatal units, a level 1 and a level 2. We started with 1 neonatal unit, and then to try and increase our capacity in terms of recruitment, because that's often a challenge with this type of work. As I'm sure you're aware, those of you who do engage in qualitative interview-based studies, it can be a challenge to recruit, and so we then extended and put in an ethical amendment to enable us to recruit within another neonatal unit, but within the same trust. So recruitment was via a volunteer basis, via our NHS gatekeepers, who were the staff, identified staff within both units, and also via an occupational therapist who assisted us hugely with our recruitment via a particular parent support group. And that was really, really beneficial to us to have her support. Purposive sampling, so quite broad overall. We wanted to interview any parent who had had a premature baby on the neonatal unit, who had since obviously gone home, but also nursing staff who currently worked in the neonatal field and had regular contact with parents who had had a premature baby. So we were quite broad with our criteria. And the participants we recruited came to 8 parents altogether and 9 neonatal staff, so total sample of 17. And as I've already said, we obviously received and applied for NHS HRA ethical approval. So yes, so our participants were made up of parents and neonatal nursing staff of various grades. Let's check the time. Okay. So that was our recruitment and our participants. So the approach to this research, we undertook, as I've said before, qualitative approach, and we used a narrative inquiry and theoretical underpinning to our work. A narrative is something that I was familiar with from my own doctorate work that explored parents' experiences and other work that we had been involved in, as I said, Lisa Whiting and myself previously. So narrative inquiry was a methodology that I was more familiar with. Involves, for those of you who are not familiar with narrative, really it's around stories, collecting stories, in this case the stories of parents and also neonatal staff. So it's a very sort of broad approach to interviewing, quite unstructured, and it enables you to collate and collect very rich data about, you know, experiences within the neonatal setting. The parent advisory group I mentioned already, and that they were recruited separately via a parent support charity, which again were hugely beneficial to us. And as I said, they were involved in the development of the data collection tools. So really the interview schedules for both sets of participants, and also the participant information sheet, etc. And they came up with some really very useful feedback about, for example, the wording in terms of them being parent facing and clear to a parent that had undergone that type of experience in the past. And so we made a number of changes to our data collection tools based on our feedback from our parents advisory group. So that was a really sort of a very positive process to be part of in terms of the sort of PPI, public and patient involvement process. Because it was narrative inquiry, as I've said, the interviews were quite unstructured. I took the interviews, so for consistency, I undertook the interviews with all of the participants, and Celia and Lisa, the other members of the team, analysed a data set each, because we had a set of parent data, so the parent interviews, and we had the nursing staff data set as well. So it meant that we could be a little bit more objective in that way, but also then made sure that we met regularly, which we did throughout the whole process, and were able to sort of verify the themes that came out from each data set. So that was our data collection. Just to say the analysis, actually, I didn't mention data analysis again, because it was a narrative inquiry. It was based on Braun and Clark's thematic analysis, but it involved much more of a sort of a narrative approach to themes, to identifying themes in a very sort of reflexive way. In terms of the time, there isn't the time to talk too much about that, but if anyone wants any more information on narrative as an approach, but also narrative analysis specifically, then I'm more than happy to send you any information if you're interested. But it's on a par with more traditional thematic analysis, which is often used within this type of work. So we had the 2 data sets. So we drew out 4 themes for each data set, and we are now writing those up. In fact, we've got 2 publications one that has been accepted and one that we have just submitted to another journal. So we're publishing our two data sets sort of separately, but obviously linking them up. But in terms of the themes, in terms of our findings from the parents, these were how we sort of labelled our themes. So firstly, the experience of parents of being in a neonatal unit, in terms of the stories that they told in the interview and the sort of the narrative that came across, they were able to recall very sort of quite stark memories about their whole journey through being in the neonatal unit, from pregnancy, from admission of their baby to the neonatal unit, and the whole, the word journey, I know it's very overused these days, but it was a word that's very commonly used in these sorts of interviews, say from the start to the current day, because we interviewed parents after they had been discharged home at various stages, various ages of the baby's life. So yeah, very much their stories was telling me really about their journey of neonatal care. And within that, of course, we were interested in finding out about communication, as Celia said at the beginning. So communication and interaction, particularly how they were supported through that from the very, very early days of finding themselves unexpectedly in a neonatal unit, with their baby being born much, much earlier than expected. I mean, in many cases, very early in the, before 30 weeks gestation. There was a variety of gestations in the 8 families that we involved. So, a lot of it was about the parents finding their way of connecting, and connection came up as a really strong theme in terms of this, needing strategies to help them bond, connect, and engage with their babies and interact with them in a very meaningful way. And there were various strategies that were used, that were encouraged by staff on the neonatal unit, a variety of different professionals, in terms of helping them find their way to communicate with their baby. Inevitably, as they spoke about their experiences, there were certainly barriers to communication. And again, that was from very early days, be it the equipment, such as incubator care, the lines, the tubes, the interference during various interventions that the babies had to undergo, being moved around the different areas of the neonatal unit, families, for example, that had children at home where parents couldn't be present all the time, and generally the busyness and the sort of hecticness sometimes of a neonatal unit environment. So that was certainly something that very strongly came across in terms of barriers and challenges to them communicating effectively from their perspective. And because they were talking about the whole of their trajectory, the transition from the neonatal unit in terms of going home, and I've found this in previous research, it's a very sort of significant event for parents, and actually going home often raises sort of new issues that they hadn't thought about before. That's when the support pillars are not there anymore. So suddenly they're faced with being at home with their very vulnerable, very small baby, and sometimes not sort of really knowing the best way to communicate. And there are other sort of areas to think about as well in terms of the physical skills, such as oxygen and feeding. But yes, communicating and finding the right way to communicate with their premature baby, bearing in mind that the babies, when they go home, are still very vulnerable and are still essentially, they're premature, so they have sort of different needs to those babies that are sort of healthy and term. So I think that transition came up as a really sort of strong area in terms of perhaps concern from some of the parents, and the sort of lack of support, particularly around the communication and getting to know their baby and knowing what was the right thing. So there was quite a number of very important areas to address in terms of what the parents said in their narratives. So we also, as I said, interviewed nurses as well. We had 9 neonatal nurses, all at different varying grades, but they all were currently working in neonatal care. Certainly, one of the sort of most positive themes for me as I listened to nurses, I spoke about their experiences, again, their stories, because they told their story of where they started out and what they'd been through in terms of their training and where they were now in their careers, their neonatal journey, if you like, as somebody working within the area. Again, one of the most positive sort of things that I think that came out from what I was listening to was how they found the working with parents, working with babies in this way, almost joyful, and it was such a positive part of their role, and they took it very seriously, and they all seemed to understand the importance of communication in some way, and recognize that it was actually a very, very significant and important part of their role, even though sometimes, again, in terms of those challenges highlighted by the parents, they had all those sort of barriers to contend with, such as skill mix and workload and busyness and dealing with unexpected events and so on. So they were very mindful, again, of the barriers that were there, but also how they really took it seriously in terms of working with parents to find ways of helping them connect with their babies. So their role within supporting parents was, again, a really sort of fundamental theme that came out, given also, how difficult it was sometimes to give that emotional support, recognising that the emotional side of care, again, those connections and the bonding and attachment around interaction and communication, is equally as important in many respects to some of the other less, I suppose, more clinical skills or areas of care. So they certainly voiced very strongly that they encouraged communication. They knew that it was important. They were very complimentary, I think the word is, about other members of the multidisciplinary team, such as speech and language therapists and occupational therapists, in terms of the team approach to helping parents, work with their babies to recognise their communication cues, and making sure that the team were there for the parents and that the parents knew that they were part of their clinical care. And then, the one thing that we sort of couldn't really ignore, because all these babies were born during COVID, actually, and so the impact of COVID was absolutely a barrier in terms of face mask wearing, the restrictions that there were at the time on neonatal, say, visiting, but parental presence, shall we say. So again, that was something that we had to address because of the timing of the research. So I'm just going to move on just because of time. So these were the examples of positive communication that came up from the participants. So obviously talking, reading, music, positive touch, skin-to-skin contact, but also timely and consistent communication with the multidisciplinary team. And of course, we know that has links to healthy attachments and bonding, enhanced connectivity and responsiveness, and also parental empowerment and helping parents develop their role and their identity as a parent. So, we know that what the potential impact of supporting positive communication is. And as I've said, we know also that, what certainly hindered communication in this context, but what generally hinders communication was very insightful, that these were all confirmed: admission procedures, interventions, equipment, as I've said, busy unit, staffing levels. And there was sometimes a perhaps lack of empathy or sensitivity and poor acknowledgement of the communication needs, perhaps by staff, through perhaps no fault of their own if they were busy and overworked. But sometimes parents did voice that as the communication with them perhaps required a little bit more sensitivity and more consistency. It's a slightly different slant there around communication. That's not communicating with the babies, but that's how staff felt that sometimes staff communicated with them, or the lack of. And of course, we knew that COVID measures at the time and face masks also hindered communication, and we've written a paper on that as well. So really, in terms of the implications now, just to finish, parents spoke highly of the communication strategies that they were taught by the various professionals, but it was clear that they did receive varying advice, inconsistent advice sometimes, and varying levels of support, particularly post-discharge. It was there in the neonatal unit, but particularly post-discharge, that was where inconsistency continued even further. And nurses also rated communication as being very important, but they were often not able to describe, and this is what Celia was talking about earlier, they weren't able to describe what they meant by communication from a linguistic perspective. So they talked about, as Celia said, skin to skin and perhaps reading, all really important things to do with babies, but there wasn't so much understanding around the links to later linguistic development and language skills, which is our particular focus now, moving forward in terms of future work. So we know that there is a need, and again, this was identified by all the participants, there is a need for clear, consistent and culturally appropriate communication strategies, with a greater awareness of basically a greater knowledge of how to facilitate them, particularly in this group of babies that are born preterm, because of their high risk of developing speech, language and communication problems, as you've seen from the evidence that Celia has presented. And failure to support parental interactions may potentially mean the creation, as Celia again said, of poor language environments. So really we've concluded so far, and this now paves the way for future work, there is a need for better training and better support resources about early communication beyond the foundation skills, those skills that we've mentioned already, you know, such as skin to skin, so on. And those resources need to be aimed at both neonatal staff and parents working together. So we've got some, I've mentioned the 2 publications that we've got in hand at the moment. Say one is accepted and one is in hand. We are developing a website, and that's just a screenshot of our website that we are developing. It's there as a web page at the moment with tabs at the top, and we are going to launch that as soon as we've completed the resources. We've called it Prematurity and Communication, so the PAC website. So just to signpost that at the moment, we will disseminate the link as soon as it's launched. So we're hoping that's going to be useful for staff and for parents. And there's still, in summary, the impact of both positive and negative communication shouldn't be underestimated. We have seen that as reported by both parents and staff, particularly moving forward in a child's future development. There's a need for positive communication, which is an ongoing and consistent theme, but as well as a need for guidance and tailored education and resources. Obviously, the parent voice is essential, which we hope we've put central to this particular staff and study, and that staff are absolutely advocates for the babies and families. So we need to know and have an ability to understand and consider how and when to communicate most effectively. And that is highly valued and appreciated, because we know the importance of facilitating parent empowerment and the importance of emotional connectedness between babies and their parents. So I'm going to finish there, because you might now have questions. We'd be particularly interested in your thoughts about future directions and where do you think we should go next. We've got some ideas, aside from applying for more funding now for impact work. You may have other questions and some suggestions for us. So thank you very much for listening. That's our email addresses if anyone wants to contact any of us. And finish there